Welcome to Cleveland Clinic Abu Dhabi podcast, the important role of speech and language pathology and what we can offer as a specialty, an important part of both the inpatient and outpatient services at Cleveland Clinic Abu Dhabi. I'm Erin, I'm an Australian trained speech pathologist and have been working for 18 years, mostly in Australia. Working here at Cleveland Clinic nearly for 2 years now. I'm particularly interested in enhancing the quality of life in patients who might be towards the end of their life and have dementia or experienced a stroke. So I'd like to welcome Hannah. Hannah, are you happy to tell us a bit about yourself?
Hi, I'm Hannah. I am a British trained speech and language therapist. I have worked for about 14 years. I've been in the UAE working for about 4 years and in Cleveland Clinic Abu Dhabi for just under 2 years. My main interests are working in intensive care and particularly for patients who've got a tracheostomy or are ventilated and for those who've got a spinal cord injury. And I'm particularly passionate about patients who have dysphagia, so swallowing difficulties, and they're looking at their rehabilitation and their management.
At Cleveland Clinic Abu Dhabi Speech Pathology, we provide quite a wide range of services across the journey from inpatient to outpatient. By inpatient, we mean a patient who's currently admitted to hospital. So they're typically quite unwell and need specialised care. When we're talking about outpatients, we're talking about patients who have now left hospital and have come to visit for one of our specialised services. And it might be that they're coming from home or another long-term care facility to come and see us. So, can you talk me through a typical day?
Okay, typically I will see both inpatients and outpatients during my day. So for the inpatient caseload, I might go up to the wards and I will see a patient for an initial swallow assessment. I then might have an instrumental assessment of swallowing, so a specialised swallow assessment. I then may go down to the ICU or to the intensive care unit and see a patient who has a tracheostomy and look at their weaning plan. So the weaning plan is when the tracheostomy is going to be removed. So it's looking at the steps towards removing it. So that can be a typical day in the inpatients. I mentioned about the instrumental assessments of swallowing. So those who are, it's a specialised swallow assessment. So we have two that we do here at Cleveland Clinic Abu Dhabi. So we have a video fluoroscopy, which is a moving x-ray of the swallow. And we have a fibre optic endoscopic evaluation of swallow, or FEES, which is a nasal endoscope, so a scope that we pass through the nose, and we look at the upper airway, we look at the throat, and we look at swallowing. So they're the specialised assessments that we do, and we do them regularly in the inpatient setting, and additionally the outpatient setting as well. I will also then see outpatients. The majority of my caseload tends to be those who have got a tracheostomy, so a tracheostomy is a tube which is placed into the throat externally to help with breathing and to help with clearing the chest. So we often see these patients as outpatients. They can be safely discharged. Patients with tracheostomy can be safely discharged home, and we'll often see them as an outpatient setting, but within that setting we need to look at their weaning and then also look at their swallowing and eating and drinking as well.
Actually, my day sounds pretty similar. I might have patients who are currently in hospital who need me to come and see them. It might be that it's for an initial assessment, a brand new patient who I don't know, who needs quite a complex and thorough assessment of what's happening either with their eating, drinking and swallow, or with their talking, understanding and use of language. It might be that they need a more formalized, standardized assessment to really find the parts that are tricky in their speech and language. This is something I might do in the outpatient setting as well, or as an inpatient, depending on the needs. I might then see a patient who has come to see me for a review of their eating and drinking, or it could be of their understanding and use of language or their talking, and this might be in the outpatient setting as well. One of the things that can be really important is being able to have access to quite skilled interpreters when we are doing those more complex language testing, especially when we don't have a shared language, and for doing the follow-through therapy. That is certainly important. I might also spend the day after having done a swallow x-ray, like you said, the moving swallow, have done the x-ray, and then I go across to see the radiologist. because I want them to have a look at something I've seen on the images, and I'm able to get them to have a look and let me know whether we need to follow up further or not. And I know that you are often going next door to see the ear, nose and throat doctor to show them your images from your nase endoscopy if you see something that you think needs to be checked and might need follow-up. So can you tell me about one of the more complex outpatients you might have, and what is it that makes this approach so specialised?
So I'd say the patients that probably the most complex that I see as outpatients are, as I said before, the patients who have a tracheostomy. So these patients can be discharged home safely from hospital with a tracheostomy. However, they do need ongoing management and ongoing support from the outpatient services at Cleveland Clinic Abu Dhabi. So I would say these patients we need to see collaboratively with the ear, nose and throat doctors and the respiratory therapists. So we need to make sure that we have a shared goal in their treatment and management to ensure that we manage these patients safely. So typically we'd see them as an MDT.
And why do you need a respiratory therapist and an ear, nose and throat doctor at that appointment?
So with these patients, when we manage a patient with tracheostomy in the inpatient setting, we have the alarms, we have observations, we can manage the patient safely with constant observation. Obviously, when a patient goes home, there's less observations, we have less staff around, so we need to make sure that patients are managed as safely as possible. So a typical outpatient day a session would be when they came in. So for example, with the tracheostomies in, there's a balloon at the end of the tracheostomy that is often inflated. When it's inflated, it means there's no airflow through your voice box, so the patient can't communicate, they can't voice. So as a speech and language pathologist, my goal is to get a patient to communicate and to talk. So we'd need to make sure that we can deflate this balloon safely and then place a valve on the end of the tube to ensure the patient can communicate verbally. To do this, it has to be an MDT approach. So we need the ear, nose and throat doctors to have a look at the upper airway. So they'd use a scope, pass it through the nose and look at the upper airway and see whether the patient is safe to deflate the cuff. Have they got an adequate airway? The respiratory therapist would make sure that the patient is oxygenated well enough. They'd look at whether the chest is clear and they'd support in deflating the cuff. And then speech and language pathologists, we'd want to place the valve and to look at, can the patient get voice? Can they communicate? Can they talk? We have to do it as an MDT approach in the outpatient setting. Otherwise, the patient could be unsafe. So we have to make sure that we have a shared goal to facilitate safe management of the tracheostomy, but also improve quality of life for the patient and make sure that when we're achieving these goals, that it's patient-centred.
That does sound complex. So in the inpatient setting, we do use a lot of specialised assessments, swallow assessments in particular. Is that something we use in the outpatient setting as well?
So we have exactly the same access in the outpatient setting as we do in the inpatient setting. Probably the management and the use of them is slightly different. So we use it much more for reviewing patients and to ensure that we are keeping on track of how a patient is doing. So a lot of the time we'll use it for patients who, for example, have a progressive neurological condition who need to be reviewed every sort of 2 to 3 months. They come in for an outpatient setting and we'll decide then whether we need to repeat the instrumental assessment of swallowing.
And what do you mean by progressive neurological condition?
So a progressive neurological condition is a condition which can deteriorate and get worse. So there are certain diagnoses that we know we need to be more aware of and be on top of their management. So for example, someone with motor neuron disease or someone with Parkinson's disease, we know their swallowing and their speech can get worse. Often these changes in their swallowing are subtle and not always picked up by family members. So the term aspiration is where food and drink goes the wrong way and into the lungs. Often this can be silent, so the patient won't cough the same as you or I do. So we need to make sure that we are assessing regularly because the family members won't pick up because the patients aren't coughing at bedside. So we need to be looking at, are they losing weight? Have they got chest infection? So when they come in for their review, we need to be asking these questions and then thinking at the time, are things getting worse? Are there sort of subtle changes? We need to be proactive in our management. So we can decide there and then on the day, should we do a FEES assessment, so the nase endoscopy of swallow? We have the equipment available. We can do it there and then. We can review the patient's regularly, and we can look at whether the swallowing is getting worse. Are things now going the wrong way? Is there changes to voice or their laryngeal anatomy? Do we need to refer to ENT, so to get them to come and see the patient? By doing this and having this access to instrumental assessments, we can be proactive in our management. We know our patients are complex. They often have multiple comorbidities. We need to make sure that they are safe, but at the same time, making sure that they have good quality of life, and that we are ensuring that they can continue to eat and drink as long as possible. So we've spoken a lot about the assessment of swallowings, and particularly in the outpatient setting. Can you talk about how you'd manage patients and think about therapy for the patients in the outpatient?
Excellent question, Hannah. It is both incredibly simple and incredibly complex. The way we treat it and manage it is really dependent on the patient and what their needs are at that time. It might be that the needs shift over time, the needs shift within the session. It might be that someone has come to me because they're having difficulty with their swallowing. We know what the problems are, and now we need to address the weaknesses. It might be that they need specific strength training for a specific muscle that's not doing its job during that swallow. It might be that we need to provide some more education to the patient, the family, and the caregivers so that everybody understands the importance of what we are all working on together. It might be that we need to work on some compensatory strategies. So while that swallow is not working as well as it should, what can we do in the meantime to keep it as safe as possible? And ideally, to develop it further so that we can get them back to eating and drinking more regular food and drinks. Similarly with the talking, can we help expand their ability to communicate what they need when they want? But how we do that will change. Will change within the session. I particularly love being able to use some of the expiratory muscle strength training tools, nice evidence-based tools where you can work on those breathing out muscles for being able to get a good strong cough, which is a nice protective measure, and being able to maintain voice. So using the same tool, you're able to work on both parts of that treatment. You're able to track it, keep an idea of what's working, what's not. I think one of the other things we might try is whether in the treatment we can look at expanding the types of foods that they can manage. Maybe we practice chewier foods, harder foods, faster fluids, all together in the safety of the clinic. So whatever the treatment is, it really depends on the patient, the family, and the goals. We like to set nice, clear goals, make sure we're all on the same page. We know what we're working towards. We set timelines, and then most importantly, we keep track of it. So we know that we are on top of where we're going and all heading there together.
Lovely. So we've obviously spoken a bit about the progressive neurological conditions and stroke and the intensive sort of tracheostomy patients. Are there any other patients that you'd see as an outpatient which differ, or your management might be slightly altered or slightly different?
So one of the areas I find more rewarding is working with adults who have developmental delays. They might become known to me while they're in hospital, quite unwell, and we come to realize that maybe actually there's something we can do to help them with their ability to communicate more effectively. So then once they're kind of well and out of hospital, they would come and see me as an outpatient, and we would work with the patient, the adult, the family, and the caregivers to figure out what it is that can be done right now, which sounds very simple, but actually requires quite complex assessment, quite complex understanding of the family, the patient, the situations that they're in. We need to identify what things are working well at the moment in terms of their communication and what things we could expand a bit more. It might be something very simple like a communication picture board. It could be a pragmatically organised communication books so that they can get their message across quicker. It might be some simple low technology pictures that they can point to, or a personalized communication dictionary that identifies all their specific ways of communicating messages. And it all sounds very simple, but it's very fascinating and challenging to figure out what the needs are, what do they need to be able to say, and what's the best way to say this, what's the best way to support it. And once we've kind of figured that out, then we get on to the training and education, making sure that everybody knows how to use this system, make sure it works, and then it stays up to date. It needs to keep working, right? So we need to keep updating it. So this is a kind of work I like to do. I might have the same patient who I'd seen in hospital. They were quite unwell, and we know when people are quite unwell, their eating and drinking can be quite affected. Now they're not unwell, they're out of hospital, they can come back and see me as an outpatient, and then we can work on trying to expand what they can eat and drink safely. It might be that we tried different foods, harder foods. We can do all of this safely in the clinic, and then ideally be able to expand the kind of things they can eat and drink safely, and that makes me very happy.
Nice.
So I think, what I also like about this is being able to have that continuity of care. We know these patients well. I've known them in hospital. We see them now. We have a good shared history together. We're able to help advocate for them. We're able to, in case of they do get sick again and go to hospital, we're able to help make sure that there's a good understanding of what they can do and where we can get back to and what we're aiming for. It might also be that we need to have more assessments, more swallow x-rays while we're in that setting. So, can you tell me about some of your favourite outcomes as a speech pathologist here at Cleveland Clinic, Abu Dhabi?
Okay, so I think my favourite outcome for patients and for managing patients here in the hospital is when we can successfully manage a patient with dysphagia. So from initial assessment to sort of treatment and returning to oral intake. So it's for those patients who we get the referral, we will carry out a fibre optic endoscopic evaluation of swallow, so a FEES, and we'll do that immediately for the patients to assess their swallowing. So we will assess the patient, and by sort of doing it immediately, we can identify what is the safest consistencies for this patient to eat and drink. So we're immediately getting rid of the risk of aspiration. But this isn't something which can be a long-term sort of modification of diet. So patients probably don't want to stay on a puree diet or thickened fluids. We want to be able to return to regular diet and normal fluids back to the patient's baseline. So we'll carry out the initial assessment, quick fix, have them on something which is safe. We'll then refer them for a video fluoroscopy, so the X-ray of swallow. For this, it can help us identify where exactly the swallow is breaking down, so we can see and know what muscles aren't working, what cranial nerves aren't working, where is it going wrong, and why is food and drink going the wrong way, or why are they struggling. From this, we can then identify our treatment plan for the patient, so we know what we should be working on, what we need to treat. We can then plan tailored rehabilitation for patient with patient goals in mind, and make it as patient-centered approach as possible. So this is where I really enjoy, and I think my favourite outcome is where you can do the initial assessment, plan the treatment, and then have good outcomes, but using evidence-based practice at the same time. So obviously evidence-based practice is where we are making sure that we are using current research, our clinical judgment and our clinical knowledge, and also the patient goals and patient decisions to make sure that the care and what we're providing is going to improve quality of life, but also be safe and effective. How about you? What are your favourite outcomes for a patient?
So my favourite outcomes, like I said, I really like being part of the journey. I think it's quite a privilege to be there from the beginning, where they're adults at their most vulnerable, sometimes unable to eat or drink anything, not even being able to manage their own saliva can be quite tricky. Not being able to use any kind of voice or their eyes or their hands or anything to communicate with us and tell us how they're feeling. And going from that point to then that first time where you see on a swallow test that actually we can give them something orally, coffee usually. And it can be so rewarding because you can see all that hard work that's gone in from the family, from the patient, from the dedicated caregivers who are following through. It can be quite special to go from not being able to eat anything, not being able to say anything, and then those first words coming out again. And it's rewarding. It's nice to be a part of that. I think then ideally when they're well out of hospital, they come and see me as an outpatient, and then we can really start working on the extra stuff. We're safe now, we're eating and drinking. How do we get back to eating steak? Like, what are the next steps? How do we do this? And with that kind of shared knowledge, mutual respect, it can be pretty special. So, anything else you'd like to share with us about speech pathology as a specialised service?
I think I just want to to highlight the effective work that we can do here at Cleveland Clinic Abu Dhabi. So we are a team of highly specialist speech and language pathologists. We can carry out thorough specialised assessments for communication and for swallowing, and for a variety of diagnoses and conditions. So voice, stammering, stroke. We can do this effectively both in inpatients and outpatients. We can carry out effective patient-tailored therapy to have good and effective outcomes for our patient as well. And we are a team of diverse specialists and clinically really good speech and language pathologists who obviously all bring together different backgrounds, different knowledge, different specialist skills to make sure that we have really good patient outcomes and effective therapy and management for our patients.
Lovely. Thank you so much for joining us, Hannah.
Thank you.
Thank you for joining us today. That's us.